Hi, so yeah, my name's Fabiana Lorencatto. I'm a health psychologist by background, so yeah, something a little bit different. I work as the research lead at the Center for Behavior Change at UCL, and I work across a range of different behavior change topics, everything from smoking cessation to self-management and diabetes. But behavior change around AMR and infection prevention control is a real focus of ours at the moment. We've got quite a few multidisciplinary programs of research on at the moment, which I'm behavioral science lead for, that are aiming to apply behavioral theory, frameworks, and methods to understand behaviors around AMR and using that understanding as a basis for designing more effective, or hopefully more effective, interventions. And that's sort of what I want to talk about today, how we can apply behavioral science to design interventions to change behaviors around AMR. In the program, my talk has the vague title of behavior change, which is quite big. Big topic. I can't cover everything, but hopefully I'll give you a flavor for how we can apply principles from behavioral science to designing interventions. So I want to talk a little bit about why behavior change in the first place and why it's important to tackling AMR. What are some of the issues, perhaps, with current approaches to designing interventions around behavior change, not just in AMR, but also in the context of AMR? A behavioral science approach, as I mentioned, I'll outline one approach that we often use and how that's being applied in two settings, antibiotic prescribing in care homes and also vet surgeons. So why behavior change? So I'm sure we've all seen these sensationalist headlines around about the antibiotic apocalypse and the real threat of AMR we're facing. I don't need to convince this audience that AMR is a real threat and an issue. But what I'm often interested in are the stats that accompany these types of headlines around, for instance, how many antibiotics are prescribed that are perhaps inappropriately prescribed. We see these a lot both in research but also in the media. However, overprescribing of antibiotics by healthcare professionals is just one of the many factors that is contributing to AMR. As I'm sure many people have seen this infographic from the World Health Organization, but there's lots of other things that are contributing to AMR. So use of antibiotics in livestock and fish farming, use of diagnostics and development of new antibiotics, infection control behaviors such as hand hygiene, isolation procedures in hospitals, but also behaviors of the patients and public, such as hygiene and actually finishing the course of antibiotics when you're giving it, and most importantly, seeking antibiotics when perhaps we don't need them. But really what I'm trying to get at here is, what do all these different factors have in common? They're all forms of human behavior. And if we look at the UK AMR strategy and some of the three key areas highlighted in it, it's things such as improving hygiene practices, reducing overuse or false prescription of antimicrobials, and increasing adherence to guidelines. Again, these are forms of human behavior. So really what I want to say here is that the complex challenge of tackling AMR relies on the complex challenge of changing human behavior. And not just the human behavior of doctors, but of lots of different people and different roles in different systems and settings, everyone from individual patients through to policymakers. So we know behavior change is crucial to AMR, but to what extent is it actually thought about or considered when we are designing interventions to change these behaviors around that are contributing to AMR? Well, there's been a number of studies by colleagues of mine that have tried to look at the extent to which behavioral science has contributed to the design of interventions to improve antibiotic prescribing as well as other behaviors. And unfortunately, although there's lots of research and lots of efforts into developing interventions to change antibiotic prescribing, most of these don't actually approach this in terms of behavior change. So very few of the interventions provide a rationale for why they use that intervention strategy, and I'll talk a little bit more about that in a second. But they don't actually consider the behavioral and social influences on antimicrobial use, design interventions based on behavioral theory, or incorporate behavior change techniques. Now, this issue is not unique to AMR per se. It's often a challenge we find in most areas around behavior change and intervention development. And often what we find is that there's a rush to intervention. We see a problem, we just have to go and do something to try to change a behavior. Especially in healthcare, where we're often pressured to do change and we often don't have time to think about it, we just rush to just try something. And what that means is that we often don't have a rationale for why we're approaching an intervention in that way or trying to change a behavior in that way. And Professor Martin Eccles, who is a professor of implementation research, the field I work in, coined the term the Lajiye principle of intervention design, which is often the basis on which most interventions to change behavior in health are often designed, which simply stands for it seemed like a good idea at the time. So interventions don't have a rationale. Instead, we base our choice of strategy for changing behavior on best guesses, hunches, gut instincts as to what needs to change because, hey, we're all humans, right? We all know behavior. Behavior's common sense. We all have our implicit hypotheses as to what needs to change based on our own limited experience of the issue, which might be right, but might also be biased or not fully representative. More often than not, it reflects this assumption that we just educate. The issue's a knowledge deficit. If I had £1 for every time a clinician came to us and said, hey, I have this behavioral issue, it's an educational issue, I'm going to do an educational workshop, I'd be very, very wealthy because it happens all the time, a rush to just doing something educational. Education, yes, absolutely key, but we all know that there are many more influences on behavior beyond knowledge. So education is just one piece of the puzzle. Or also this notion that it worked elsewhere. So again, I've had people approach us saying, well, we know public health campaigns are really effective in smoking, so let's take some of the principles that worked for smoking and apply them to AMR. That works to an extent, but the influences on smoking are potentially very different to the influences on antibiotic prescribing. So we can't take an intervention that's worked in another context for another behavior and simply transplant it into a new setting. But this often happens all the time. So why is this a problem? Sometimes Lajiye works, great. More often than not, it doesn't. Because sometimes, as I say, we're targeting perhaps the wrong thing. If we make an assumption that knowledge is what needs to change, and we do an educational intervention, maybe we're not actually tackling the real issue if knowledge deficits aren't a barrier in the first place. If you're lucky and as Lajiye works, great, but if we want to learn and replicate or scale up an intervention, we can't necessarily do that if we don't know what the rationale was for that intervention or what was actually in your intervention and how you did it. And we can't also learn from implementation failures or unsuccessful interventions, which I would argue is equally important. So what we have are essentially black boxes, which are often behavioral interventions. So I want to talk about a slightly different approach to designing interventions to change behavior, which is the approach we often take in behavioral science. And the analogy we often use to describe this process is, let's say, going to see your GP with some symptoms. You would hope they wouldn't just rush to prescribe you a treatment, although sometimes that does happen, but in an ideal scenario, you'd hope they'd first examine the problem, make a formulation or a diagnosis as to what condition you actually have, and then prescribe the choice of drug or treatment that best fits your symptoms. Sounds straightforward, but why don't we approach behavior change in the same way? Why don't we do a diagnosis of the behavior of interest, understand what are the symptoms, so the barriers and enablers to that behavior, and then choose a choice of intervention strategy that matches those symptoms? Now, doing this type of behavioral diagnosis-based intervention development is facilitated through the application of the behavioral and social sciences. There's a wealth of different disciplines that are purely dedicated to scientifically studying human behavior. So psychology, which is the discipline I come from, but also sociology, politics, history, geography, all sorts. Now, this is usually when I stop and give a sort of health warning. There are no magic bullets or universal truths that this is what's going to work to change behavior. It's very important to be clear about what behavioral science is and isn't. So we don't offer magic bullets, which is often what the perception is, but rather, and we wouldn't wish to do that either, because rather we believe that interventions to change behavior should be based on an understanding of what's driving that specific behavior in context. And we can offer theories, frameworks, and methods that enable us to understand behavior in depth and in context, and to use that to design interventions to more effectively change behavior. And I'm going to talk today through the steps of the behavior change wheel approach, which is an approach that was developed by the research group that I'm based in at UCL. And it offers a number of interrelated theories, evidence, and principles for designing interventions. And it's basically tools to help guide decision-making and facilitate a step-by-step, transparent approach to intervention design. So avoiding is Lajiye and opening that black box of interventions. And we're increasingly applying it ourselves, as well as other groups, to try to understand some of the behaviors contributing to AMR and to design antimicrobial stewardship programs. And as I said, I'm going to talk about care homes and vet surgeons as an example. So in a nutshell, these are the key steps in the behavior change wheel approach to intervention design. First of all, defining your problem in behavioral terms and being as precise as possible as to what behavior you're trying to change. Doing a behavioral diagnosis to understand behavior and context and identify barriers and enablers to change. And then looking at the broad range of intervention strategies, and as I said, matching your choice of strategy to your behavioral diagnosis. And there are tools and frameworks that can help us, and principles that can help us at each step. So starting with what behavior you're trying to change. So sounds really obvious, but often is overlooked or isn't done very well. So defining your problem in behavioral terms. Reducing infection rates isn't a behavior. It's an outcome of lots of different behaviors that contribute to that. So often we start with the end product that we want to achieve or the outcome, but we don't actually think about what are the behaviors that are contributing to that outcome. So working backwards, sort of thinking about what are the different constituent behaviors that might be contributing to infection rates. Could be things like, and let's take a hospital for instance, hand hygiene, use of protective clothing, disinfection and cleaning of surfaces and instruments, maintaining appropriate isolation, antibiotic prescribing. Lots of different behaviors which in themselves can be broken down further, and we'll talk through that in an example in a second. But also it's important to realize that these different behaviors don't occur in isolation or in a vacuum. They actually form a system of different behaviors that interact with one another, sometimes in a positive way where they can facilitate one another, or in a negative way where they can compete with one another. So for instance, hand hygiene, just as a microsystem of behavior, let's take nurse hand hygiene behavior. Sounds like something straightforward and simple and specific, but actually the nurse's hand hygiene behavior might be influenced by the behavior of their colleagues. So senior doctors perhaps modeling good or bad hand hygiene practice and a culture of hand and hygiene practice. The behavior of peers influences that, and there's evidence of that in the literature. Patient behavior, so patients demanding that a nurse disinfects their hands before coming into contact with them, or even the behavior of domestic staff of making sure that gel is available at every dispenser when needed and topping that up. Different people, different behaviors interacting together. So the first step is to map out that system of behaviors to identify where best to intervene and how. And not just mapping out these behaviors, but trying to be as precise as possible. So if I set myself the New Year's resolution of trying to be more physically active, fine, that's a behavior. But I could be more specific and define that in more precise behavioral terms. So I'm going to go for a run 3 times a week in the park in the mornings. Much more likely to succeed if I set myself, if I define a more specific goal or a different behavior that I want to change. It makes it easier to design an intervention and plan strategies to change that behavior, but also to measure success. So if I actually manage to change the behavior. So we often say, start by asking yourself who needs to do what differently, when, where, and how often. So for instance, nurse ensuring that they clean their hands using alcohol gel at the patient bedside before and after every physical contact with patients. Much more precise, much easier to measure, and more focused design. But anyway, let's move on to applying this to antimicrobial stewardship, which I think is a case example for the need to actually stop and think about what behavior it is I want to change, because antibiotic prescribing on its own is not just a behavior, or antimicrobial stewardship is not just a behavior. It's actually an umbrella term for lots and lots of different behaviors. There's different people involved at different time points in, let's say, in a hospital setting, the care continuum, in different settings, and doing lots of different actions. So taking hospitals as an example, I was just in the workshop on the multidisciplinary antimicrobial stewardship team, and I thought there were some really nice examples of this behavioral complexity in AMR. So the different roles of the hospital pharmacist, the stewardship nurse, and microbiologist, et cetera, interacting and doing different things to contribute to managing a suspected infection. But the behaviors are different, and there's different people involved, and we need to recognize that. So everything from suspecting an infection, maybe communicating that, documenting that, ordering a diagnostic, collecting the samples adequately, those are behaviors, processing the samples, actually accessing the test results, discussing that with your colleagues, checking it against guidelines, making a prescribing decision around dose, duration, type, again, documenting that, stopping to within 48 hours, let's say, reviewing, deciding whether to switch, stop, or continue. These are all different behaviors. And if we shift gears to vet surgeons and companion animals as an example, this is a study hot off the press, actually, quite timely, applying these principles to understand antibiotic prescribing for vet surgeons who work with companion animals. Similar, deconstruct that into different behaviors. So confirming the clinical need for an antibiotic, responding to clients and having that communication with clients around perhaps expectation or demand for antibiotics. I'll talk a little bit more about that. Confirming the diagnosis, again, deciding the dose duration, preventing infection through surgical interventions, etc. lots of different behaviors contributing to AMR, or antibiotic prescribing, sorry. So lots of behaviors, we need to map them out and understand and break that down. But we can't always intervene with everything, and we'd often recommend not doing that. It's much better to start small and build, so almost start small and focus, but less is more. So intervene intensively on one or two key behaviors that are perhaps feasible to intervene on, you have the resources to do, and also that might have a knock-on effect on others. But really, I think the whole point of this exercise that's important is when you move on to the behavioral diagnosis stage, which is the one I'm going to talk the most about today, and also the one that I as a psychologist find most interesting. So behavioral diagnosis is all about understanding why behavior is as it is. So if we have lots of different behaviors and lots of different actors, there's going to be lots of different things influencing whether or not a diagnostic is used, decision-making around antibiotic prescribing, whether or not those decisions are documented, communication behaviors. All those behaviors will have different drivers, and they will vary across individuals, organizations, and settings. So we need to be specific about actually whose behavior we want to change so that we can go do a behavioral diagnosis with at that particular time point with that particular group. And use that situational assessment to understand behavior and context. So this is Professor Susan Mckee. It's a caricature of her when we were both giving a talk that was done in real time when she was describing this step. It's sort of asking yourself, why would people actually change? What are the individual, social, cultural, and environmental factors that are driving behavior? What needs to change? So why is behavior currently as it is, and what do we need to change for the desired outcome to occur? And if we remember that all these factors contributing to AMR are forms of human behavior, then we can use theories of human behavior change that have been used to predict other behaviors to try to explain and predict AMR. And so we can answer these questions by drawing on behavioral theory and using social science methods. Now, there's lots of different theories out there, 89 theories of behavior change across different disciplines. And we don't really have a good rationale for choosing one theory over another. So there have been efforts in our discipline to actually try to pull together and synthesize different theories of behavior change into a minimum set of conditions or factors that need to be in place in order for behavior to occur. And this is one effort to synthesize across behavior change theories, and it's the COMBI model, or COMBI system of behavior change, which says 3 basic conditions need to be in place in order for behavior to occur. There has to be the capability to perform the behavior, the opportunity, and the motivation. So this is perhaps one of the most simplest models of behavior change, but also quite comprehensive. And if we break that down further, so what we mean by capability, an individual has to have the psychological and physical ability to do the behavior you want them to do. So they need to have the knowledge, the skills, they need to be able to remember to do the behavior, pay attention to do the behavior when it happens. And by skills, we don't mean just physical skills, but also the social skills, which are we'll see how all of these are important to AMR in a minute. Motivation, these are things both in terms of reflective, so things that I am aware of, such as my beliefs about what will happen, around consequences, whether it's something I value, the behavior is something I actually want to do, if I feel it's a behavior that's relevant to me, how confident I am in performing that behavior, as well as perhaps less conscious, more automatic behaviors that happen, such as emotions and habits, and response to rewards or incentives. These are motivational drivers that can influence whether or not a behavior occurs. An opportunity we can also split further into 2. So physical opportunity, do I have the necessary resources, time to perform the behavior? Do I have access to the context I need in order to perform the behavior? But also the social environment can influence my behavior in a positive or negative way. So social norms, peer pressure, peer support can influence a behavior as well. So our starting point is often, when conducting a behavioral diagnosis, is to use a range of methods to ask questions around whether the person whose behavior we want to change, whether they have the capability, opportunity, and motivation. You can use a range of methodologies, but today I'm going to talk about a social science methodology of qualitative research, which often is things like interviews and focus groups. So going to speak to the people whose behavior you want to change and asking questions around COMBI to try to understand which one of those is actually driving behavior. Is it capability, opportunity, motivation, a combination of both? And there's been an increasing number of studies over recent years that have been applying COMBI to do a behavioral diagnosis of behaviors that are contributing to AMR and antibiotic prescribing, for instance. So I'm going to talk about one study now that was done in Ireland in care homes. So care homes has high rates of inappropriate antibiotic use that's contributing to AMR. This group of co-authors did a study using COMBI. They did interviews with a range of different actors. They interviewed GPs, nurses, healthcare assistants, community pharmacists, as well as care home managers. And they structured their interview questions around COMBI. So, for example, to tap into capability, they asked around whether the individuals had an understanding of AMR, whether they knew about it, understood what it was, did they understand what antibiotics can and cannot treat, guidelines for appropriate antibiotic prescribing, procedures for correctly diagnosing and treating infections. So this is to tap into psychological capability and physical and social skills. To ask about motivation for this behavior, they asked around what these people thought were the consequences of prescribing versus not prescribing an antibiotic. Did they have any concerns about prescribing an antibiotic or not? Is promoting antimicrobial stewardship part of their role? Do they think they have a role to play, or is it actually someone else's responsibility? How motivated are they to do that? What are the competing priorities? And are there any incentives or rewards in place to encourage them to use antibiotics less? And then in terms of opportunity, in terms of physical opportunity, they ask around things like time, access to diagnostic tests, different types of antibiotics. And then in terms of social opportunity, they asked around things like team working dynamics, communication, the influence of residents and their relatives, and as well as other healthcare professionals. So I'm not going to go through every single thing they found. I would recommend reading the paper. It's really interesting. But I'm going to give you a flavor of some of the themes they found under capability, opportunity, and motivation when they were doing this behavioral diagnosis. So all of them were aware of AMR. So again, knowledge wasn't the issue here. Everyone knew about AMR and recognized that it was a growing public health threat. However, there were some knowledge gaps. So they were unaware of their own antibiotic prescribing rates and AMR rates locally and what the ideal targets were for using certain antibiotics. Guidelines, some of them were aware of what the guidelines were for appropriate prescribing, others weren't. And those that were familiar with the guidelines often said the guidelines aren't adequate. They're not necessarily specific to the unique patient group in a care home, which are often frail, elderly, lots of comorbidities. So translating those guidelines to that context presented challenges. And then also uncertainty around diagnosis of infection in long-term care patients with comorbidities that don't always have clear signs of infections. So skills around being confident in making an accurate diagnosis were limited. Motivation. Emotions played a real strong driver in this context. So fear came up a lot, fear of missing something and potentially harming a vulnerable patient if they didn't prescribe an antibiotic. And there was a general consensus of we have to avoid hospitalization at all costs if possible. So if that means over-treating with antibiotics, that's preferred over and above the threat of AMR and a patient potentially going to being hospitalized because we missed something by trying to reduce antibiotic use. Although they were aware of AMR, they didn't think that prescribing in care homes necessarily was contributing to the broader threat of AMR, sort of care homes being seen as an isolated context, and that the motivation to try to protect antibiotics on a wider scale for the public good wasn't really what was driving prescribing in a care home. They were much more about the individualized patient and the patient care plan and their familiarity with the patient and their history. That was what was motivating their prescribing practice rather than antimicrobial stewardship. And also, although they were aware of the need to preserve antibiotics, it just wasn't that high of a priority. They have many other clinical issues to consider. Antimicrobial stewardship just really wasn't that high up on the list. Physical opportunity. On-site in care homes don't always have access to diagnostic equipment needed to make a diagnosis or to get timely interpretation of microbiology test results. Doctors often aren't on site. It's often an off-site GP that comes to the practice or having to make prescriptions over the telephone, which means that sometimes doctors are making prescriptions without even having the test results back, not even actually seeing the patient, so sort of relying on what the nurse was saying over the phone in terms of symptoms and sort of, rather than making a visit out to the care home, just sending the prescription over the telephone. And also this sort of toxic mix of limited staff, high staff turnover with very high pressure and workload meant that there just wasn't time or a culture for quality improvement. Again, the physical opportunity to actually engage in quality improvement and stewardship just wasn't there. And socially, again, really interesting. So there was a lot of talk about nurses playing this key gatekeeper role in terms of identifying suspected infection, organizing the clinical assessments, and escalating these issues. And sometimes their presence and actions were seen as a pressure by doctors and pharmacists, who often felt pressured to prescribe or weren't able to challenge. Also, lots of pressure from patients' family members who are often demanding an antibiotic. And another example of social opportunity, pharmacists saying that they were really keen to be more involved in antimicrobial stewardship, but just didn't feel empowered or welcomed to come into the multidisciplinary team meetings and engage in discussions around stewardship when they occurred. Now, applying this to antibiotic prescribing in vet surgeons, this study was literally published 10 days ago, so perfect timing, by a group up in Glasgow who did qualitative interviews with 16 vet surgeons who work with companion animals. And although they didn't base their questions on COMBI, they did a behavioral diagnosis asking broader questions, and they're then going to use that and the other frameworks I'm going to present in a minute to develop interventions. But I thought it's still worth presenting what they found. So they asked very open questions from their interviews around how antibiotics are currently used, what are people's understandings of AMR and stewardship, what are the factors influencing prescribing, and what might be the barriers and enablers to engaging in efforts to improve antibiotic use. I've structured some of their findings according to COMBI because they fit quite nicely, and it's nice to compare to the other. So again, knowledge wasn't the main deficit here. It was actually a facilitator, so good knowledge of AMR, but they felt there was also a need to increase public awareness and reduce expectations around antibiotics. Similar themes here, so the fear of missing an infection and potentially harming the patient, but interestingly, concern over clients complaining if they miss something and something bad happens to the pet. And that might lead to disciplinary action, let's say, if a complaint's formally logged, so there's a real fear of that. This notion that prescribing to companion animals doesn't necessarily contribute to AMR. So although they're motivated around AMR in general, whether their prescribing in their practice was actually going to influence overall AMR. And also this notion of habitual practice and patterns and ways of working. So new grads coming in being really motivated to prescribe less, but over time being worn down and just engaging in a culture of prescribing more. In vet practices, it's an interesting dynamic. So in terms of opportunity, talking around the tensions of trying to maintain a viable business and that relying in part on client satisfaction. So if I don't prescribe them an antibiotic and they're demanding it, they'll just go to another practice. So actually seeing in order to maintain the client, maybe prescribing's better. Clients really pressuring and demanding for an antibiotic, so wanting a quick path to recovery for their pet, not wanting to wait it out, so feeling like something's happening and being done to try to treat the symptoms. Diagnostics perhaps not being used optimally because of their cost of doing tests, of extra tests, and the time of waiting for results, again, similar to what was found in care homes. And this notion of prescribing etiquette, which also has come up in surgical prescribing in hospitals, of perhaps when sometimes you witness your colleague not prescribing appropriately, but not feeling like you can socially go and challenge them. So this culture of, well, I'll focus on my practice, but not try to encourage my peers or tell them, hey, maybe you're not doing the right thing here. And also interesting, this notion of perhaps from a policy angle, decoupling prescribing and dispensing opportunities in a vet surgeon. So if you can prescribe and dispense on site, makes it much easier to prescribe, but maybe if you had to separate the two, that could potentially be an enabler to using less antibiotics. But anyway, how do we use this very rich behavioral diagnosis information to move from diagnosis to actually choosing an intervention strategy? So I hope what those two studies shown, and there's lots of further studies showing a similar thing, is that there's no single influence on antimicrobial prescribing in different settings. It's a complex behavior influenced by an equally complex combination of factors beyond knowledge deficits. So we need to acknowledge that and consider a broader range of strategies to change behavior beyond just education, and match the choice of strategy based on our behavioral diagnosis. Doing this is facilitated, again, through use of a framework. As psychologists, we love theories, we love boxes and arrows, we love frameworks, but they do make life just a little bit easier. So ideally what we need is a framework that defines and outlines the range of different types of interventions out there, and that gives us some kind of mechanism to link, as I said, the choice of strategy to our behavioral diagnosis. There's lots of different frameworks out there that define the different types of behavior change interventions. And our group did a review of these different 19, and we found 19 different frameworks from different disciplines, from health promotion to environmental and culture change, social marketing, etc. What we found is none of these frameworks were comprehensive. So some of them said, okay, these are some strategies you can use to change behavior. Another one said, oh, here's some strategies, but neither of them covered all of the other strategies that were in the other frameworks. And none of them linked the strategies to a model of behavior change. And some of them focused more on attitudes, others more on social interventions, etc. So basically, none of them on their own were comprehensive or sufficiently adequate. So we just synthesized them. Again, trying to reduce complexity by integrating frameworks together to provide one comprehensive tool that is easier to use to guide decision making. And this is the product of that synthesis, the behavior change wheel. Some of you might have seen this in The Guardian over the weekend. Diane actually referenced this in terms of its contribution potentially to AMR, so thanks for the shout out on that. But so at the core of the behavior change wheel in green is the COMBI model. So you have the determinants of behavior, so capability, opportunity, and motivation. And around it in red are what we call intervention functions. So intervention functions are simply broad categories of means by which we can change a behavior, so intervention strategies. We have our beloved education, so you can change behavior by increasing knowledge or understanding. This is another one that people are probably quite familiar with and have heard of before, nudging. Falls under environmental restructuring. That's another way to change behavior. So changing something in the environment to try to make it easier or more difficult to do the behavior on perhaps a more unconscious level. So things like putting fruit and vegetables higher up in the line of vision in a shop so that you're more likely to pick them, and sweets being out of sight. Although shops do this the completely different way. They put chocolates at the checkouts to nudge you towards buying chocolates when you're on your way out. But nudge is one that often people think of. But the reason I've pointed these two first is that just to flag that these are just two of many different ways in which you can change behavior. So as well as educating or changing the physical and social environment in some way, there are 7 other functions you can use. So you can change behavior by persuading someone to do something, incentivizing them, coercing them. We don't do that one that often because that is quite ethically challenging to get that approved in research, but things like taxes for drink driving, that's a coercive strategy. Training, enabling, modeling, and restricting opportunities to engage in the behavior. I'm not going to talk through each of these in detail, but just wanted to flag that there's lots of different strategies you can use to change behavior. And interventions often use more than one strategy. So slightly different example, but I think this illustrates this point quite nicely. So here's a campaign to try to discourage smoking in pregnancy. It's one image, but it's doing lots of different things from a behavior change perspective. It's educating you about the harms to your baby and yourself of smoking during your pregnancy, but it's also persuading you by using visual imagery to make that message more salient and to increase the relevance of it. But crucially, it's also enabling you to do something. So here's a telephone number for a helpline or support service you can use to access support. So it's not just using threat and raising awareness of the issue, but also giving concrete actions. And I do think there's more that can be done around campaigns around AMR, actually, to move beyond just education to actually include persuasive and enabling functions as well. But education, persuasion, enablement, very high level descriptions of strategies. And these different functions are actually made up of smaller behavior change techniques. So if we think of the function as the cake, behavior change techniques are the ingredients that contribute to the cake. So things like eggs, flour, and sugar. So examples of behavior change techniques are things like setting goals, making plans, monitoring your behavior, giving a reward or an incentive, giving someone feedback on their behavior, demonstrating the behavior, or persuading someone about capability. There's actually 93 different behavior change techniques that have been identified in the behavioral science literature. And these are, again, summarized through another framework developed in our discipline called the Behavior Change Technique Taxonomy, which basically defines and organizes 93 different BCTs. This is our Bible, our encyclopedia that we often use when designing interventions. But how do you pick? There's 93 techniques, there's 9 functions. Which one do I pick to address what I identified in my behavioral diagnosis? So different functions are likely to be, and techniques are more or less relevant to different barriers and enablers. So let's take, for example, the function training or the behavior change technique, behavioral practice, and rehearsing the behavior. And let's say the behavior we want to change is increasing my physical activity by getting me to play basketball and training me to shoot hoops more effectively. That strategy is only going to work where the main barrier is me not having the skill, which I don't, but if I do, so I could probably benefit from this. But that function is not going to work if I'm not motivated to do the behavior, or I don't have access, let's say, to a gym, so I don't have the opportunity to do the behavior. So different functions are more or less relevant to addressing different barriers within capability, opportunity, and motivation. So for instance, to increase capability, we can do education and training to build knowledge and skills. We can motivate someone by persuading, incentivizing, coercing, or modeling to increase motivation to engage in the behavior we want and reduce motivation to engage in competing behaviors. And we can restructure the physical and social environment to increase opportunity. And we have different matrices that have been published that help guide this decision making based on evidence in the literature. So simply, this is just another way of representing this. So if on the left is COMBI, and along the top are the different intervention functions. So if you found that most of your barriers fell within reflective motivation, it says which intervention functions are most likely to be relevant and appropriate. So what we're finding is studies are using these frameworks to do all those stages in the behavior change wheel approach to design antimicrobial stewardship interventions. And this is the example in that care home context of how they've moved from that initial COMBI analysis in their interviews to identifying possible intervention strategies using the behavior change wheel. I don't have the example for vet surgeons because literally that research is underway as we speak, but their plan is to use the behavior change wheel to then move on to designing interventions to address those barriers they identified in their interviews. But back to care homes. In that paper, they have a really nice table that shows the potential strategies they're going to try based on their behavioral diagnosis and behavior change wheel. So they list the COMBI component and the behavior change technique and function they selected using those frameworks. And just one example from that very long list in the table. So if we take that barrier of staff in care homes being unaware of antibiotic prescribing practices locally, not believing AMR is an issue necessarily in care homes, and not having clear targets and guidelines for appropriate antibiotic use in their context. This is those barriers around capability and motivation. On that basis, they selected the functions of persuasion, enablement, and education, and these techniques. But just to translate that into more concrete terms, they suggested a suitable intervention in this case would be, for instance, audit and feedback. So setting targets for antibiotic use based on best practice guidelines, monitoring practice locally, and then providing feedback on current prescribing rates, deviations from guidelines and best practice tailored to that patient group, benchmarking against other care homes, as well as the AMR rates locally, and providing that over time. Basically, everything is legit, isn't. There's a rationale for the choice of intervention. It was guided by behavioral theory. It incorporates behavior change techniques. And importantly, is a transparent, stepwise approach to designing interventions. It helps unlock that black box. And on my final few key points, because I'm aware of time, also, I know I said not to learn about things that have worked elsewhere, but behavior change is not just an issue in AMR, and there's a huge wealth of evidence in the broader behavior change field and literature that can help inform the design of strategies to change behavior in AMR. So using just that example of audit and feedback that I just mentioned, this is something I work in a lot in the context of blood transfusion, totally different, but there's a whole literature on what makes for more effective audit and feedback. So if you decide audit and feedback is what you want to do to reduce prescribing in care homes, evidence from the broader literature says, well, it's going to be more effective if you give feedback more than once in writing and verbally, if it's delivered by a respected peer or colleague rather than an external source or regulator, if you accompany that feedback with action plans for change and recommendations, so not just saying you're performing badly. You're performing badly, but here's some things you could do to improve your performance. Using multiple comparators, so how you're doing relative to your peers in the same geographical region or top 10%, and using a supportive rather than punitive tone. The list goes on, but basically look beyond AMR when it comes to behavior change, because a lot of the issues we face in AMR are also faced in other areas to which behavior change is key, which are very many when it comes to public health and health promotion. So does it work? It's still early days, as I said earlier. In general, there's evidence that theory-based interventions are more effective than those that are not. When it comes to AMR, there just simply haven't been that many trials of interventions that are based on good behavioral science and evidence theories and principles. But where it has been trialed, there is a growing evidence base to support the effectiveness of using behavioral science to design AMR programs. So here are the references for one trial that did precisely that. It used multiple behavioral science theories to design an intervention focused on training clinicians. I think it specifically was GPs in using point-of-patient tests and communication skills training. And they found that if they trained them in that, it significantly decreased antibiotic prescribing, and they trialed this in 6 European countries, but particularly if they received both. So communication skills training was particularly key. And we reduced antibiotic prescribing without increasing other adverse outcomes, such as cost, repeat consultations, or hospital admissions. But caveat is, it's still early days, and we need more behavioral science-informed intervention design to answer this question of does it work. There's lots of trials underway. Here's the links to 2 trials I'm currently involved in. Last year, the different research councils actually put out a call for multidisciplinary work around AMR that brings together the different disciplines. And there was a specific theme on social science and behavioral science and AMR. So we've got 2 programs of research that are using this behavior change wheel process to design interventions to reduce antibiotic prescribing in primary care, secondary care, community pharmacy, care homes, as well as general public seeking and consultation behaviors. So please watch this space. We're still in the early days. We're just starting our behavioral diagnosis, but hopefully we'll soon be able to have our theory-informed interventions. And if any of you are students at UCL who might be interested in getting involved, we have huge scope for research projects around these 2 studies, so please do get in touch. But just to summarize, behavior change is absolutely key to tackling AMR. It's a complex behavior, lots of different behaviors, lots of different influences. Yet we often don't think about these when we're designing strategies to improve antibiotic use across different settings. So rather than rushing to interventions or designing interventions based on the Lajiye approach, we need to perhaps stop and invest some time in understanding behavior and context first, and using that understanding to develop more effective and targeted interventions. Behavioral and social sciences can help. We offer lots of evidence, methods, theories, and frameworks that can facilitate this process, but also maximize cumulative learning. And as I said, lots of studies, mostly still at the behavioral diagnosis stage, but I think there's lots of scope for further multidisciplinary work to help maximize the potential for behavior change in AMR. So thank you very much. And just to flag, this is a paper we wrote and published just a few months ago that actually goes into this in a lot more detail in case that's of interest. Thanks.